How can we increase the predictability of GBR? First, primary wound closure. Second, angiogenesis. Third, space creation and maintenance. And fourth, wound stability. Today, I brought a clinical case that followed these four principles. Hello, I am Dr. Park Jung-chol from Hyo Dental Clinic. It's great to see you again through Journal Inside. Today, I would like to talk about a paper that I believe is very important. It is a journal about past principles to ensure predictable bone regeneration, published by Dr. Hom-Lay Wang in 2006. What matters the most in implant treatment is placing an implant on an ideal position. Little alveolar bone makes it hard to place an implant in the first place. That is why we conduct GBR on an area with bone defect to recover the bone and place an implant. This journal is about how we can increase the predictability of GBR. The author, Dr. Hom-Lay Wang, put forth four principles to ensure predictable GBR. First, primary wound closure. Second, angiogenesis. Third, space creation and maintenance. And the last is wound stability. We will look into each of them today. First, primary wound closure. There are two types of wound healing process. First concept is primary wound closure, and the second is secondary healing. In the primary wound closure, wound edges will be approximated to ensure stable healing without being disturbed by external stimuli or any bacteria. That is why this primary wound closure is mostly recommended in GBR. Next, in the secondary wound closure, a wound will remain open without approximation. This healing process would require more collagen remodeling, thus healing can be delayed and scars may remain. So the paper says that the primary wound closure should come first without membrane exposure to ensure bone regeneration as much as we want in GBR. Membrane exposure can frequently happen when we use non-resorbable membranes. To address this issue, we are required to use resorbable membranes, thereby decreasing such risk. Using resorbable membranes will reduce the risk of exposure, and it would not need the secondary surgery, by which I mean another procedure to remove the membrane. And the biologically beneficial characteristics of collagen membranes will significantly reduce the risk of membrane exposure. What is the most important in primary wound closure is to make an incision and suture well. The paper highlights the importance of a flap design, tension-free suture, and the use of resorbable membranes to guarantee primary wound closure. The second principle is angiogenesis. It means that blood supply should be ensured. The paper cites a journal published by Dr. Schmid in 1997. Here, the red arrows indicate capillaries, and the black ones mean new bone. The experiment paper showed that there is nothing like new bone regeneration without blood vessel formation. So, we need to practice some clinical techniques to ensure blood supply. As one of them, intramarrow penetration, so-called cortical perforation technique, was introduced. Next, the third principle is space creation and maintenance, by which I mean we need to secure space for new bone regeneration. When Dahlin mentioned GBR for the first time, he talked about the importance of blocking the epithelial and connective tissues and securing a separate space where slowly moving osteoblast can proliferate and form bone. That is why the author has argued it is important to secure a separate space with a membrane and keep it as it is. When explaining the primary wound closure, I mentioned that a resorbable membrane could promote the primary intention without the wound coming apart. A resorbable membrane can surely be helpful in that manner, but the membrane itself is not advantageous in securing space. Thus, when using a resorbable membrane, you should use supporting material, such as bone graft material, to create a space and then go with the maintenance process. Lastly, the fourth principle is wound stability. Here, the author discusses the role of a barrier membrane from two perspectives. The first role is to create a separate space by excluding unwanted cells, as mentioned before, such as epithelial and connective tissues. The second role is to stabilize the blood clot inside the separate space. Blood clot should be kept stable to ensure smooth healing. I brought one case to help your understanding. On the top pictures, you can see that the membrane was stabilized with a bone tack, and on the below ones, fixation was made with sutures. The CT sagittal plane view shows quite a difference in the amount of bone formed on buccal side. This is a confirmation that the membrane should be fixed well so that blood clot can be maintained inside and new bone can be generated as much as we want. Next, the author talks about an implant's stability. In the case of implantation accompanied by GBR, mobility of the placed implant will interrupt the fixation of the implant itself and the bone graft material as well. Then, fibrous encapsulation can occur. That is why we need to ensure the stability of the placed implant if we want to get the surgery results we want. I brought a clinical case that followed all these four principles. For this case, implant placement was planned for number 35 and number 36, and GBR was accompanied due to the horizontal bone atrophy. In the intraoral photo, you can see that the alveolar bone showed a lot of buccal atrophy. And when opening a flap, crestal incision was performed by splitting the keratinized gingiva in half. I didn't make a vertical incision. As in this case, for the mandible, we can pull the flap both from lingual side and buccal side. So unless there is any issue with visibility, vertical incision is not a must for primary wound closure. The higher primary stability, the better. But decent primary stability to the extent of fixing the implant will be enough. And then for angiogenesis, I performed cortical perforation. Next, to have the primary wound closure, I conducted lingual flap advancement technique on the lingual side and made a releasing incision on the buccal side to pull the flap. It was followed by graft material. I applied a resorbable membrane and used a small screw to stabilize the membrane. You can use a bone tack. It doesn't matter what to use if it can fix the membrane like this. And then I sutured to obtain primary wound closure. When suturing, I try to make sure that connective tissues come together. After removing stitches 2 weeks later, you can see the wound approximation like this. And then, this is the photo taken 5 months later in the secondary surgery. As you can see here, the site healed well without the flap being exposed. This is because I used a resorbable membrane to close the flap. When I opened the flap in the secondary healing, I could see that new bone formed well on the defect area. Bone was regenerated above the implant level, so I removed some of it. When compared with the photo at the initial visit, you can see that lots of bone was regenerated on the buccal side. And this is the status after treatment. In GBR, bone regeneration itself is important, but keeping the newly formed bone is important too. If you open a flap in a way maintaining the thin keratinized gingiva on the buccal side, soft tissue attachment will be facilitated, thereby keeping the newly formed bone for a long time, while ensuring the depth of the vestibule. This is the status 4 years later. On the CT, when comparing photos taken at the initial visit after implant placement, 2 and 4 years later, you can see that cortical line has formed well like this on the buccal side. Formation of bone with enough thickness and its maintenance for a long time indicate that GBR was successfully done. Also on number 36 site, you can see the new bone formation at a very decent level around the implant and buccal side. Let me summarize the points. Dr. Homlei Wang picked the several key principles for predictable GBR procedure, which are evidenced by biological characteristics. He pointed out 4 principles and named them PASS principles. If you follow these basic principles, I believe you can perform successful GBR in a predictable way. That's it for today. I will be back with another good paper next time. Thank you.